Welcome to Healthbeat, where we check the pulse of our healthcare system. I'm Nia Malan. In August last year, President Cyril Ramaphosa signed a controversial health compact with some sectors in the country to prepare for the rollout of national health insurance. One key promise: to employ doctors more effectively, to close staffing gaps, and to improve coordination between private and public healthcare. But it's almost the end of February, and many newly qualified doctors don't have jobs, even those who choose to work in the short-staffed public sector. Instead, they're protesting in the streets. Being a doctor was once a guaranteed career. Now many are scrambling for work. Even moving overseas isn't a quick fix. The UK is struggling with placing doctors too. US foreign aid freezes and President Donald Trump's executive order to cut all funding to South Africa could affect the jobs of over 15,000 healthcare workers, some of them doctors. That's according to Health Minister Aaron Motsoaledi. We spoke to a newly qualified doctor in the Eastern Cape about finding work in a public hospital.
Medicine is in Dr. Teresa Brimmer's blood.
Are you a runner?
Not really.
No.
Her father is a urologist, her uncle a cardiologist.
So I was encouraged from a young age to pursue medicine as a career. My dad's very passionate about his job, he loves what he does.
After her degree at Stellenbosch, she interned at Frere Hospital in East London.
And then finally got placed for my ComServe in a place that I'd never heard of before, but had a wonderful year there, which was at Madzikane KwaZulu Memorial Hospital in Mount Frere, or Kwabaka as the locals call it. I really loved working with patients, actually building a relationship with some patients. You know, you can actually walk a road with someone to recovery. I've always wanted to work in government, and I've got a passion for the Eastern Cape because I grew up here. My idea was to, stay working in government as a medical officer in the Eastern Cape.
But Teresa can't find a job in a public hospital.
What I was told when I approached people was there's no posts due to financial constraints.
So this qualified doctor with a passion for helping people whiles away her time back home in Gqeberha, or online considering her options.
Trying to see what opportunities are out there. I've also applied in other provinces as well. I'm hoping to stay in the Eastern Cape if by April I'm not employed, or I'm not sort of in the process of seeing that things are heading in a direction. I'm going to have to then either go into private practice or consider going overseas. I'm holding out that I'll be able to work in government because that's really where I want to work, but I can't hold out forever. I'm not sitting now with debts that I have to pay, student loans and things like that, but I'm just worried about doctors that are being forced to see 40 patients in a day. I mean, that leaves you with very little time to care for each patient. So that's what I'm worried about, is just that the community that we want to serve isn't being served properly.
The problem is well diagnosed. Professor Ames Dye from the South African Medical Association, SAMA, is helping to find solutions. Ames, thanks very much for joining us. Now, do I understand the problem correctly? South Africa is producing more doctors than what the state sector can employ, but the state sector has many vacancies. It doesn't have enough doctors. Is that correct?
The problem is the state has fallen behind in its obligation to employ doctors to deliver the healthcare to the patients in need. With the state freezing posts, and now the latest 1,800 doctors not being employed, it's a huge indictment on the state, because we're far behind what the World Health Organization actually puts forward as an appropriate ratio of doctor to patient. It's 1 to 1,000, and we just 0.3 to 1,000. So, no, we're not producing enough doctors, I would feel. I think we still need to produce more doctors if we need to reach that ratio. The state needs to provide employment for them.
But the state says they don't have the money to do that.
I don't fall for that. I do believe that there is enough money, but the money is being mismanaged. There's inefficiencies, and of course there's huge corruption. Let's just look back at between 2009 and 2013. It was close on to 24 billion that was lost due to corruption. When we look at just over a year of COVID, from between April 2020 and June 2021, what's being investigated is 14.8 billion, I think, that was lost to corruption. So how can the state say it doesn't have enough money?
What other ways do we have if we want that equitable healthcare? Would the NHI be a solution?
I think we must differentiate between the Act and the NHI itself. What SAMA supports is universal access to healthcare. And I think the NHI Act focuses just on finances. So I don't think the Act would be the answer in terms of reaching that universal access. Now, when you look at the World Health Organization and the 6 pillars that we require for universal access to healthcare, we're looking not just at financing, but we're looking at service delivery. We're looking at workforce. We're looking at essential medicines. There's governance, and there's health information systems. So we need all 6 to come together before we can say, yes, we're going to have universal access to healthcare that is sustainable. The problem at the moment is, when we look at what's happening on the ground, I don't think that even if we're going to work towards implementing the NHI Act, we can justify patients not having access to healthcare at the moment because of the inefficiencies.
Where do we find the money from in the short term to give those unemployed doctors positions in the state sector where they desperately need it?
So it's been estimated that you require about 2 billion rands to employ these doctors. And I think what the state needs to do is look at its spending and look at where it can actually cut down on the frills and use the money that's spent on frills to actually service these doctors. We have an over-bloated cabinet.
Ames Dai, thanks very much for your time today. After the break, does the government have a remedy?
Our interns and community service doctors are earning way too much.
Welcome back. South Africa trains doctors in government hospitals, but it doesn't have enough money to employ all of them there, forcing many into the private sector, even though the public sector desperately needs them. Our team spoke to 3 doctors considering their options.
Dr. Simon Fraser was finishing his community service in the Northwest Province when the rumours he'd heard became real.
Round about November, December, it became clear that the Department of Health was freezing posts, especially in the more favourable places, Western Cape and Gauteng. Gauteng in particular was saying we're not hiring new medical officers at this time. And it's amazing how quickly bad news travels.
Simon and his young family had made sacrifices so he could specialise in orthopaedic surgery. His hospital had the department, but not the jobs.
Hi Chomi, Dr. Katlego here, and I am the lead of Curati. Okay.
In 2023, Dr. Katlego Lekalakala faced the same reality. Community service had shown her the kind of doctor she wanted to be.
I really wanted to stay in the hospital that I was at and stay in the department I was in, which was psychiatry at that time. But it wasn't possible.
With no posts in sight, private practice felt like her only option.
I was very anxious. I mean, I have a house to pay off. I have bills. I mean, I have a child to take care of. And I don't know exactly how I'm going to do that without an income.
A friend offered her space in a practice, but it wasn't that simple.
You need to also have like a network of doctors, people that you can rely on or trust in, to refer patients. I didn't have that system.
She soon learned that being a doctor and running a medical business were poles apart.
I stayed with it because it was also an income opportunity. You can have the entrepreneurial mindset, but you need to have something that motivates you, that is the passion behind it. There's just too many uncertainties. I can deal with uncertainty, but not that many.
And this from someone who'd thrived under pressure and uncertainty while working at Charlotte Maxeke Hospital during the COVID-19 pandemic. There, she made friends with fellow ComServe doctor Nico Matebula.
He struggled to get into a clinical post in the state. He branched out, It does mean that you need to invest in more studying. You have to do other short courses.
After his ComServe, Nico spent 2 years working for a private company that places doctors in emergency rooms. Now he's using that experience to run his own practice with a bigger purpose.
The niche that I'm looking at is young professionals as well as MSM and LGBT plus communities. Unfortunately, a lot of practitioners aren't sensitized to the unique needs of those communities.
Some surveys show running a private practice costs over 800,000 Rand a year. Just to stay afloat, a doctor like Nico has to bring in 71,000 Rand a month.
I think it very much depends on your setting, your area, and the service that you aim to provide. But you are definitely looking at spending hundreds of thousands of rands before you can efficiently and properly run the practice.
Simon is treading water, paying the bills by working for a private company while waiting for that elusive registrar post. Ireland and Canada are calling, but he wants to stay here to lighten the load in hospitals that need more doctors.
Ultimately, patients pay the price. Ultimately, it's the gogos that are leaving home at 5 o'clock in the morning to make sure they're sitting in the front of the queue at the CHC to get their antihypertensives. They are the ones paying the price.
To understand how the biggest employer of medical doctors sees the solution, we're joined by the official responsible for hospital services and human resources in the National Health Department, Dr. Percy Mchlati. Percy, thanks for joining us. We're sitting with a problem. We have too many doctors in the private sector and too few in the public sector, but the government says it doesn't have the money to fill all the vacancies in the public sector.
The acute problem we have is those health professionals that have just completed their community service. So what we are facing, Mia, is actually a youth unemployment problem. So whatever solution that we look for in health cannot be just for health. Are we getting the value of employing these doctors or not?
Are we?
Well, I think to a large extent, yes. But there are instances where we think that there are leakages. For instance, around overtime. There are people who contract for overtime, get paid for overtime, but don't work the overtime. That is a function of poor management at facility level.
So why is that system not managed properly?
From a national department, we've got a very clear policy on. And what we're insisting now on the provinces is to say, manage this thing properly, because that is where you are losing a lot of money from a value point of view. And you can link that to our medical legal claims that have actually shot up simply because we've left juniors to actually supervise themselves. The seniors are not there. They've got to clamp on that to make sure that people give time and value for what they've been employed to do.
Percy, let's just talk about how much do doctors in the state sector earn. A medical officer who's just completed their community service and they're now a junior medical officer. My understanding is that they enter the system, if you add the overtime, at R1 million a year or more.
That's true.
Is that too much?
Our interns and community service doctors are earning way too much.
How does it compare to other sectors?
I know that with the legal profession, many of the guys that were actually doing their first year of working would actually be earning 15,000-20,000 a month. But you look at our guys in the health service, they would actually, with overtime, they'll be earning about 80,000-90,000. So that's quite a huge differential between the two.
There were long negotiations for health professionals to be paid properly, and I'm sure they're not going to be happy if you say the solution is to pay them less now so that we can have more doctors. So what is the solution?
If you actually use part of that money of commuted overtime to employ 10 more doctors, there will be less demand for them to work overtime, and you'll actually have more hands to be able to look after patients. Then it means that people will go back to earning their basic salary.
So are you doing that?
That is what we're working on. Some provinces now have started tightening the belt to say you will only work overtime up to 8 hours, not more than 8 hours.
Almost 8 hours per week or 8 hours?
Per week, yeah, of overtime. So basically what then that results in is that they would be able to save up to about 50% of what they pay on overtime currently. So if you were to aggregate that across the country and make sure that the rostering does not actually make those who are working to be overworked, you pull in a lot of your private doctors to actually assist, you'll be able to save on that.
One of the problems we face with doctors is not just with entry-level positions, but specialists. There are constant complaints that there are not enough specialists or registrar positions for people to become specialists.
We should be training more registrars and in the various fields, not concentrated in surgery or medicine or obstetrics and gynecology. But the challenge we have is the capacity to train. And in many instances, it's actually jointly universities and provincial departments that do that funding.
How do you see this shortage of doctors and registrar positions playing out under the NHI? Will it help to improve the service?
From a training point of view, the NHI is not going to provide money for training of doctors. That funding would still be through the Department of Higher Education and Training.
Do we have enough health professionals to run out an efficient NHI?
Well, I would put it this way. I think we've got a fair number of professionals to be able to provide universal access to healthcare services, which would be funded by the National Health Insurance Scheme.
It's not just doctors, it's also other health professionals that we face shortages of. And now with the pulling of foreign aid by the Trump administration, the health minister says there are 15,000 positions of health workers that we may lose. Does that worsen things for us?
Yeah, in the short term it does, but in the medium to long term, I don't think it would have such a major impact. If there is one lesson to learn really is to make sure that we do not end up with long-term dependencies on donor funding or foreign aid, which is then goes back to an economic issue for the country. If we pull together as a country to make our economy grow, we'll be able to mitigate on many of the issues that we're facing.
Dr. Percy Mokhlati, thanks very much for your time today.
Thank you, Mia. Thank you.
After the break, meet the specialists who are finding another way. You're watching Healthbeat. We're at the Wits Donald Gordon Medical Centre, South Africa's only private teaching hospital. It's keeping much needed specialists in the country. I'm joined by Professor Jay Pillay, the clinical head of vascular surgery at the Wits Donald Gordon Medical Centre. Jay, thanks for your time. We do appreciate it. You're a private teaching hospital. How does that work and who do you train?
It's quite a unique situation that we have here because you're absolutely right. It is, from all perspectives, a private entity. But it has this unique link with the University of the Witwatersrand. And I know other hospitals have attempted to do this, but it's quite an onerous process to do. But by link with the university, it allows us two opportunities for teaching and training, predominantly. One is the teaching and training of registrars who are registered with the state with the intent of becoming specialists. So although that responsibility is still with the state, we do have a facility here for teaching and training. In other words, those individuals can rotate through various departments for a different kind of training, and the hospital doesn't charge for that. Now, more important than that, there is what we call a subspecialist program, which means that individuals who have a basic fellowship degree, like a general surgeon, for example, can then become a subspecialist, which means they train to be a vascular surgeon or a colorectal surgeon. Now, the Donald Gordon provides funds for those and employs those individuals on a routine basis.
So Jay, where does Donald Gordon get the money from to fund the subspecialist positions?
So the hospital is a private hospital, so the funding model is no different to any other private hospital. The difference is those funds are then re-enters a pool for teaching and training rather than looking at profitability. And that's the big benefit. So that mechanism of almost a private entity assisting in teaching and training is somewhat unique. But the funds come out of the private entity, in other words, medical aids.
Jay, we have many doctors who can't find positions in the state sector because they can have permanent positions there as opposed to consultancies in the private sector. What does that tell us about our healthcare system?
I think it's a policy-driven problem that we need to address. And how we do that is difficult to envisage. I think part of the issue, if you look at the Donald Gordon system, it's almost like a private-public partnership indirectly, because a lot of what we're doing is sort of free for the public sector and for universities, for example. So whether we can re-establish that, whether we can copy that kind of thing is extremely important.
So are you saying that Donald Gordon could potentially be a model for the NHI?
The fundamentals of it is that the budget will be run by the state, and whether we have a Donald Gordon model or another private hospital model, the funding model will come to each of those. I do think that where things can change is that if every hospital, be it private or public, under healthcare reform, can concentrate on all parts of medical care or healthcare. In other words, just not the service providing and the income stream. In other words, all hospitals will have to look at teaching and training, would have to look at research, would have to look at creating structures for innovative medicine. And that's where NHI or any other healthcare reform may change things. I mean, that's what we hope that will happen in the long term.
Jay, do you think the NHI could work?
We have a presidential summit and a compact that's been signed in 2018. We have the same thing that's been done in 2024, and the first pillar of that was human resources. And then suddenly we get to the stage where people are unemployed. Now, that could either mean two things. It means that whatever we're trying to attain is not doable, because they're not being employed, or it may mean that a system like NHI is imperative to sort out that problem. I think the problem is when and how. In other words, if NHI is the thing that's going to happen in 10 or 15 years from now, we have an immediate problem. So I don't know whether NHI can work. I think it's very much an experiment in a country like South Africa. But I do know that some sort of reform is imperative.
Jay Pillay, thanks very much for sharing your time and insights.
Thank you.
That's Healthbeat for this month. If you have comments or ideas, you can email us on health@bekasisa.org. Keep well.